All right, good afternoon. So I'm Kevin Kerber. I'm thrilled to be here. Thank you to Kristen for the invitation. And so I'm going to talk about more outpatient vestibular cases. So this is basically, we started with basically acute cases, and now we're moving on to more kind of chronic cases that you're more likely to see in the outpatient setting. So let me just get this advanced here. Here we go. All right, so just a generic case. 55-year-old female presents with recurrent episodes of dizziness. The onset was about 3 years ago, so it's in the chronic category. And then she recalls episodes even dating further back. The dizziness is described as an internal spinning sensation, also has significant nausea. The duration of the episodes is hours. During the episodes, can function a little bit, but is really bothered by the symptoms and they're worse with any movement. She also reports sensitivity to light and sound, and with some of the episodes, there's an associated headache. Past medical history, migraine headaches. Exam, normal, and the specific parts of the exam that we really try to focus on are hearing. If there's any obvious hearing loss, you don't have to be really precise on this. A lot of it is based on their subjective symptoms. In this sort of situation, we're looking for large hearing abnormalities, not really subtle things at the bedside. Normal ocular motor function, normal head impulse test, and I'll show you some examples of those being abnormal, and normal walking and positional testing. That's kind of the neuro-otology battery when we're saying those things look normal. In this is the typical circumstance of what's being labeled vestibular migraine, migraine-associated dizziness, benign recurrent vertigo. It's come by multiple different names over many years, but vestibular migraine is kind of being more commonly used. There are now diagnostic criteria for vestibular migraine that are listed here that try to be specific in some of the criteria for these things, but the clinical practice, you have to kind of be a little bit flexible. These criteria say you have to have at least 5 episodes with vestibular symptoms. What if you only have 4? So there's flexibility with these things, obviously, but the episodes can vary widely in their duration, 5 minutes to multiple days. There are definitely some people who would fit this category that start morphing into chronic constant symptoms as well. The person usually has a current or previous history of migraine with or without aura, and with one or more of migraine features with at least 50% of the vestibular episodes. And not better accounted for by another diagnosis, which is basically what you see on exams. So not accounting for something else by a better diagnosis is basically that there's not significant hearing loss, there's not ocular motor abnormalities, there's not an abnormal head impulse test, gait is normal. So we're basically looking at those things. And then probable vestibular migraine kind of eases up on a little of these. My personal opinion is migranous components are really nearly ubiquitous in anybody you're seeing with dizziness presentations, particularly us when we're usually seeing them after 1 or 2 steps. So like take benign positional vertigo, for example. The severity of benign positional vertigo ranges from trivial and a party trick, which is, watch what happens to my eyes when I tilt my head back. Like some people are not really bothered by that, to I'm calling 911 and going to the emergency room, it's so bad. And my general impression, I don't know what you guys think, the people who are calling 911 and going to the emergency room, they are extremely sensitive to motion. They didn't like roller coasters. There's anxiety components to it also. There can definitely be a BPV severity component to it. More particles, more severe nystagmus. The horizontal canal tends to be more symptomatic. You can see by the videos that were shown before how fast the nystagmus oftentimes moves in horizontal nystagmus. It's some of the fastest nystagmus that we see. So there can be those variations, but oftentimes these are people who are just sensitive to motion. They have baseline migrainous components, and so it's, we all know this in neurology. I mean, you can say this for probably many, many different neurologic conditions, that the people who are most bothered by it tend to have extra susceptibility to it. But these are the criteria as described, if you want to be specific about it. In terms of treatments for vestibular migraine, there are no FDA-approved treatments, and summary systematic reviews are that the overall evidence base for vestibular migraine treatment is of low quality, and that this is definitely the case. If you look up medication migraine preventatives in what's presumed to be vestibular migraine, you'll find papers, but if you actually look into the design and what was done in those papers, these are usually observational studies, pre-post studies, and ones that have a lot of bias associated with them that don't give us a whole lot of confidence that there's actually a medication effect. And there's not like pre-post designs where there's no blinding. This is one randomized controlled trial that did blind and was placebo-controlled of metoprolol in patients who had vestibular migraine. And there was no difference in the outcome because, look, the figure there shows the control group and the intervention group. And I mean, have you ever seen lines that are closer to overlapping than that? That basically patients at enrollment started out with about 8 episodes per month, and both the placebo and the control dropped by more than half. So either the controls are having a placebo effect, or it could also be part of the natural history. As you know, there's a placebo effect with most anything, but I do think this is a condition where the natural history is favorable. And I oftentimes really try to tell patients that because they come in and they're extremely anxious, and they've been through some tough episodes, but they're really in a category where the outlook is optimistic. You can almost guarantee that their episodes are going to get better just with time. You can't really necessarily be specific on the time or how much better, but the natural history is quite favorable in this circumstance. But if you move into a category where the patient is still bothered by symptoms and they want to try something, the general approach that I take with preventative treatments is just really kind of base it on comorbidity. So, if anxiety is a component of it, tend to favor tricyclic amines or SNRI. If there is a blood pressure component of it, beta blockers, candesartan, something like that. Certainly seizures, topiramate, and generically topiramate as well. So we will try those, but we don't have rigorous randomized controlled trials in those circumstances. And I'm personally usually not convinced, even if we start something and the person comes back and feels better, I'm rarely convinced that it's actually the medicine at that point. So what I tend to do is if I'm going to use these, I tend to try to minimize their side effects on them also. So start low, go up very slowly if you're going to do that is kind of a general approach that I kind of take to it. We can talk about that more at the question session. For acute episodes or symptomatic management, this is just generic descriptions of our most common medicines, Dramamine, meclizine, Phenergan, Zofran, and what we're looking at in terms of their benefit from clinical trials, that the first-line treatments, clinical trials suggest about a 40 to 60% reduction in dizziness and a minimal increase in drowsiness. When we move on to the second lines, Ativan, Valium, or benzodiazepines, we tend to have a little bit lower reduction in dizziness and a little bit higher increase in drowsiness, but you do see some patients who are really so bothered by it when you have these really severe acute vestibular neuritis cases that they probably would like to sleep for a little while and they don't mind being sedated, which, by the way, when you fall asleep, your vestibular system shuts down, and so that can help these patients in general. There has been a clinical trial of rizatriptan in vestibular migraine that is still only published in abstract form. We're still waiting for the full analysis. I'm not sure why it's not out yet, but it was a study where they measured many different outcomes, and most of the ones that were specific to dizziness did not show a significant difference in the time periods that were measured acutely, like 1 hour, but they did find a reduction in symptoms of unsteadiness or dizziness at 24 hours, the difference being 80 or so percent versus about 70% in the control group. So, not a large difference there, and that was after measuring multiple different outcomes. And so, but we're still waiting for the full trial of that. On clinicaltrials.gov, at least Emgality is undergoing a clinical trial in vestibular migraine, so we're still waiting on that. So no news there. Okay, so moving on to case 2. So case 2 is a 65-year-old man. This one is less specific to age. I thought about just deleting age because this is just kind of a generic presentation, presents with dizziness and balance problems, started about 3 years ago and started using a cane about 1 year ago. So it's basically, it's chronic and it's slowly progressive is the gist of this. And I'm going to go through 2 different scenarios to talk about probably the 2 conditions that if things are missed, it's usually one of these when we see these kind of chronic dizziness patients. And so scenario A is on exam, the person has impaired smooth pursuit. Saccadic pursuit is another label for it. These are not saccadic intrusions, because saccadic intrusions are intrusions that are involuntary eye movements that impair on gaze. So square wave jerks are saccadic intrusions. Saccadic pursuit is a voluntary saccade because your smooth pursuit system isn't working well. So from a technical standpoint, it's not a saccadic intrusion, it's a voluntary saccade. But because the smooth pursuit system isn't working, you're only using the saccade system to track objects. And also has mild persistent gaze evoke nystagmus. Those 2 usually go together, impaired smooth pursuit and gaze evoke nystagmus, and that was right beat on right gaze and left beat on left gaze. Also some subtle signs of dysmetria, rapid alternating movements are somewhat impaired, and speech is mildly dysarthric. So this is in the category of a mild cerebellar dysfunctions, mild cerebellar ataxia. And this, I just want to show this video of these eye movements that I'm talking about, which are saccadic pursuit and gaze evoke nystagmus. This, I feel like, particularly smooth pursuit is a very undervalued exam component. People rarely look for it. For me, when I'm seeing a patient with a chronic dizziness, it's probably my most helpful sign. That if I could pick one thing to look at, it would probably be how well are they moving their eyes as they track across. And so this is just one side to one side. Here I'm holding the eyes out here a little bit to see how long the gaze evoke nystagmus persists. Because usually we only call it abnormal if you're at 30 degrees and it's persistent. So something along the lines of more than 5 beats, essentially. And this person has that. But as this person tracks across, you'll see what are cogwheel movements, essentially, that it's chop, 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 as they come across, because their smooth pursuit system is not working. So for them to make voluntary eye movements, they have to either use their vestibular system and move their head really quickly, or their saccade system, so it's saccadic. And that is very localizing to the midline cerebellum. If you're taking an exam and they ask where does impaired smooth pursuit localize, you'll say it's nonspecific, because when you think of global brain problems, they can affect that. But most of our patients are cognitively intact, and that's where if you see saccadic pursuit in a person who's cognitively intact, it's highly localizing to the cerebellum. So that's what we're looking for in this situation to evaluate patients for cerebellar disorders. This is what it looks like on a tracing. So we have people test smooth pursuit and vestibular testing, which is just a target that tracks back and forth. And if it should be smooth, the smooth lines are the target, and then you can see the choppy lines. That's the person's eye movements as they're moving across, and it's chop, 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 chop. One of the cool things about this is really anybody can mimic impaired smooth pursuit, because you have to be tracking a target to have smooth eye movements. And so it's a great thing to show medical students if you want to, if you're saying this is what this looks like. First, have just track a target back and forth, just your thumb, and that should be smooth. And then, unless you've been drinking, and it might slow down a little bit or something, so don't do it in that sort of circumstance. And then if you do it without a target, so if you just imagine that you're looking at a target and tracking across, you really cannot generate smooth pursuit. You can only use saccades, so it's going to be saccadic. So you can just show the difference between tracking a target and trying to track an imaginary target, and it's you'll get the impaired smooth pursuit, saccadic pursuit, in that sort of circumstance. This is just a paper that I came across. In neurotology, we tend to see the subtle cerebellar ataxias that come through, not the profound ones. And there has been some advances in our understanding of these subtle cerebellar ataxias, which used to be very idiopathic. And so this was a review that was done a few years ago that really brings out the SCA27B and also RFC1 related canvas syndrome, in addition to SCA6, which are probably our three most common specific genetic disorders that will present with these subtle, usually late onset ataxias that can be really dominant ocular motor abnormalities rather than dominant dysmetria and dysarthria, and so they can fall in that sort of subtle category. So there has been some advancement in our understanding of these, at least from the genetic standpoint. For the management, though, it's still across the board in these patients really relies on supportive management, physical therapy, occupational therapy when symptoms are bad. Many patients in these categories will be very mild for an extended period of time, but we can at least pull them out of the medical vortex of just test after test after test, seeing specialist after specialist after specialist. We can say this is what it looks like and this is how we're going to follow it. For medications, the only FDA-approved medication in ataxia is the one for Friedreich's ataxia. There's an interest in 4-aminopyridine, particularly for SCA27B, but if you look at the reports of these are still really early phase studies that are pre-post. They're really designs that are high risk for bias. One of them compared patients pre and post with the use of 4-aminopyridine in people with SCA27B compared to a non-SCA27B cerebellar ataxia syndrome. And the conclusion was that the 27B patients are responsive because they have less of a worsening than the non-27B patients. But there might just be a difference in the conditions rather than an effect of the medicine. We don't really know yet. Ryuzal, as you know, had a randomized controlled trial a number of years ago at this point. I think this dates back to like 2015. And had a trial in 60 patients that did show a mild difference in the outcome measure of the cerebellar ataxia scale, but we're talking about 1 to 2 points on a 40-point scale or something like that. So there's certainly not a profound effect there. And there was a follow-up study to that. That was in a mixed cerebellar ataxia group that was many different SCAs. Then there was a subsequent study specific in SCA2, which was proposed to be the one that would most likely be the most responsive to Ryuzal, and that study was negative. So we're not really sure at this point whether or not it's worth going through a trial of it, but if you do, it's going to be borderline on whether there's going to be a significant effect that might be hard to determine once you start down the pathway of using the medicine. Okay, so scenario B, basically the same presentation, a chronic dizziness imbalance that's dates back 3 years and is mildly progressive. The other thing, so now let's imagine that the cerebellar specific components of the exam were normal. So there was normal smooth pursuit, no gaze-evoked nystagmus, no dysmetria or dysarthria. And now the head impulse test shows abnormal bilateral corrective saccades. So this is our other situation of a condition that can sometimes be missed because it can be subtle and hard to pick out, and this is a bilateral vestibulopathy. And this is a video of an abnormal head impulse test. You saw the ones that Dan showed a minute ago. I like this one because for me at least, it just shows up really well in the video. That first head impulse, she just has a very long delay until she moves her eyes. This is only to the right. A bilateral vestibulopathy, you will see the corrective saccade on both sides. And you can test these at the bedside. You don't need any extra tests. If you're used to doing the head impulse test, the thing that you do have to do if you're going to do the head impulse test is you have to move fast. Like even when I'm training residents, there's such a hesitancy to move the head. We're not moving it very much. Only like 5 to 10 degrees is all we're moving it. But it's got to be fast, because if you don't move it fast, the person can use smooth pursuit to stay on target. Because if you turn the head, you can either keep your eye on the target with smooth pursuit or the vestibular system, but the smooth pursuit system only works at low frequencies, so you got to go above that really to get it to a pure vestibular category. But I am very comfortable with only this. I don't feel like my patients need to undergo vestibular testing to check for subtle problems with the vestibular system. I mean, you can really do it at the bedside. So this would be a bilateral vestibulopathy in this sort of situation. One unique thing about these patients is that they very frequently, and it makes sense, will describe their dizziness as their vision is bouncing when they're in motion, so movement-induced oscillopsia. If there's a specific dizziness, type of dizziness description, it's probably this. I rarely hear people say this without it going down that pathway of perhaps a bilateral vestibulopathy versus vertigo is so nonspecific. Types of vertigo, they can throw you lightheadedness. Some people with vestibular disorders will describe lightheadedness. Many people without vestibular disorders will describe vertigo. But it's really rare that we hear people really say things are bouncing when I'm walking and actually visualizing them. And so that's one specific symptom to listen for. I wouldn't necessarily probe for it, so don't just start asking everybody, do you have bouncing when you're walking? Because we get into these situations where everybody's answering yes to everything. But if somebody says it, pay attention to it. And so the etiologies here are usually, we really focus on ototoxicity, gentamicin. The first thing I do when I see somebody like this is I type in the search in Epic gentamicin to see if I can pick it up anywhere throughout the past records. But people who get it are usually sick and in the hospital, so they can usually describe that sort of scenario. You can have a bilateral Meniere's disease. The autoimmune inner ear disorders are usually really fulminant and will have severe progressive hearing loss. So I'm not going down that pathway unless I'm hearing that sort of circumstance. And then there's idiopathic, which is very common, presumed genetic. Why are there so many genes that we know for hearing loss, but basically none for pure vestibular loss? We haven't, it probably has to do with being able to capture the phenotypes well enough and large enough samples, but almost certainly there's many different genetic causes of vestibular loss based on having so many with just hearing loss. And our treatments focus on physical therapy and optimizing other sensory systems. So these are people who I try to spend a lot of time with. You got to be careful in certain environments. If you're living in cold weather, make sure to get some extra traction on your shoes. Lights are important in the house. If they had, God forbid, they get diabetes and they start developing peripheral neuropathy. It's amazing how well a really healthy person with a bilateral vestibulopathy can function when everything else is working well, and it's terrible to see how they're functioning when they start losing other things. If they lose vision from diabetes and peripheral neuropathy from diabetes, then it can be extremely bad. Okay, so moving on to my last case. So this is a 65-year-old person, presents with constant dizziness, reports lightheadedness, internal spinning at times, feeling off balance, no significant auditory symptoms, but has really relevant past medical history: hypertension, diabetes, depression, sleep apnea, off CPAP, prior MI, on a number of medications for these. The exam is basically normal ocular motor function, normal head impulse test, no focal neurologic deficits, maybe a little bit of slowing of walking speed, but balance is normal. This is really a very common one. What the precise label for it is not clear, but this is basically, this person has an enormous amount of medical issues that are contributing to dizziness and balance problems. And this is really underappreciated. Like, I almost feel like at the time we get referrals from primary care doctors, we should have some calculator that says probability of dizziness based on known medical conditions. Because when you start adding these up, about 15 to 20% of the population will say that they've had problems with dizziness in the last 12 months. And it just starts going up the more medical conditions they have that are associated with it. And certain ones like vascular and also mental health ones are really prominent, and also migraine. And so you have like 3 or 4 of these, and all of a sudden your probability of having some dizziness is more than 50%. So sometimes I have to restrain myself to say it, but we would be more surprised if you didn't have dizziness than if you do have dizziness. And that's the reality. Like, it's so common. And so there's a trial where they really used a multifactorial approach to patients presenting with dizziness that used all these different components that showed that approach in the intervention group has about a 20% decrease in dizziness, and the control group stays about the same, about a 5% decrease. So this broad approach is something we should really be paying attention to, particularly in this circumstance of people who are highly likely to have medically associated dizziness. You can say the same thing about mental health. So, that I described an older person with this, but if you have a younger person who has migraine headaches, depression, anxiety, insomnia, and fatigue, once again, the probability that person is going to have some dizziness is more likely than not. So we look for things that we can, that might change our category. So it's still important to look and make sure that there's no signs of cerebellar dysfunction or specific vestibular dysfunction, but usually there's not, and they're in this category of a chronic symptom syndrome that's really related to their baseline health conditions. Okay. So to address these patients, really awareness of their general medical and lifestyle factors, what are the drivers of the probability of dizziness, optimize general health and mental health. You really try to emphasize this to the primary care doctors, I think, is key. Sometimes our notes are very brief, and I think that sometimes primary care doctors get that, sometimes they don't. So whether or not to have a one template that says this is why I think this is in the mental health category might help them along the way. Physical therapy can be tried for some of these patients. Gaze stabilization exercises is the trial to the right, where gaze stabilization exercises are generally precise to people who have a unilateral vestibulopathy, but there have been benefits to patients in a milder form, so where patients who are treated with gaze stabilization exercises who have a chronic dizziness that could be of this type might experience more of a decrease in their dizziness compared to controls. So maybe some of these people have a not fully compensated vestibulopathy from years ago or something like that, or there's something else about the exercises that gives them some benefit is not known, but it's certainly reasonable to try, and things that they can do on their own. The reference at the end is an online guide that was made by this group that did this study in England, and it basically walks patients through gaze stabilization exercises, so it's a good resource. And then, again, trials of medications can be used based on comorbidity, but none of these are FDA approved or really studied well in this sort of circumstance. So the summary here is vestibular migraine is chronic, frequent, recurrent episodes without hearing loss or abnormalities on their neurologic and neurootologic exams. Cerebellar ataxia, really psychotic pursuit and gaze evoked nystagmus are the key findings in that sort of circumstance with patients who have mild presentations of this. You have to be careful that the person's participating. This comes up all the time on vestibular tests that aren't done very well with a good technician. Because if the patient is not paying attention to the target during the test, it'll look like that. Like I was saying, if they're not on the target and following the instructions, it could say psychotic pursuit, worried about central cerebellar dysfunction, and then you look at it at the bedside and you're like, okay, it's fine. So, you know, that comes up on vestibular tests a lot. Bilateral vestibulopathy, abnormal head impulse test bilaterally is what we use for that. And then really, you know, be aware and appreciate medical and mental health multifactorial dizziness, because it's very common. And I will stop there. And I think we're going to have questions at the end. Yeah, okay, all right, excellent.